So I'm Marissa Town. I am the clinical director for children with diabetes. I have had the privilege of attending Friends for Life conferences since I was a teenager, and now I work in diabetes. And I have worked at Stanford University for the past few years, more so when I lived in California than now. And that is where I got to meet Dr. Prahalad. And she has done some incredible things. So Priya Prahalad is a clinical associate professor of pediatrics and medical director of clinical informatics at Stanford University and Stanford Children's Health. She completed medical school and a PhD in cell biology at Georgetown University. She completed her residency in pediatrics and a fellowship in pediatric endocrinology at UCSF before joining faculty at Stanford University. She is leading quality improvement initiatives in the Division of Pediatric Endocrinology and is the site lead for the T1D XQI Collaborative and Sweet Pediatric Diabetes Registries. She's also co-lead of the North American hub of the Sweet Peer Review Program. Dr. Prahalad's research interests are using technology to improve outcomes and decrease health disparities in youth with type 1 diabetes. So welcome, Priya.
Thank you. And I want to thank everyone for attending today. Give me a minute to just pull up my slides.
Yeah. And I was just going to say also, before we get into it, if anyone has questions, feel free to use the Q&A or the chat feature. And what we'll do is we'll go through the questions at the end.
Okay. Well, thank you for joining today. I was asked to talk about some practical tips for people with diabetes that we've learned from participating in various registries. I don't want to overload you with data, but I really want to share with you what registries can help people with diabetes for and what it can help clinics improve their care. So I want to start off by talking about what is quality improvement in healthcare and what role registries play in this. I want to expand on that and talk about some successes from quality improvement-based registries, as well as then reviewing some data that we have from both the Sweet Diabetes Registry and the Type 1 Diabetes Exchange Quality Improvement Initiative. Registries are really important because they do help highlight disparities in diabetes outcomes. And I think it's important that we all are aware of those. And I have a fun little story about how we've applied the learnings from the registries to improve care at Stanford Children's. And then I'd like to wrap up with some practical learnings for parents and people with diabetes, and then discuss some future directions of the registry work. So first, I really want to talk about what quality improvement in healthcare is. So it's a framework that's used to improve the way that care is delivered to patients. There are processes that can be measured, analyzed, improved, and controlled. And QI entails continuous efforts to achieve a stable and predictable process and to reduce process variation. And that's not to say that care is not individualized, but really the goal is to make sure that everyone receives at least the same standard of care. And it's also important to improve outcomes for patients and healthcare organizations. And achieving a sustained quality improvement initiative really requires commitment from the entire organization, including top-level management. So registries play a huge role in quality improvements. So a registry is really an organized system that uses observational study methods to collect uniform data. Typically, it's clinical data, and to evaluate specified outcomes for a population that are defined by a particular disease, condition, or exposure. And the goal of these registries is to help improve scientific, clinical, or clinical results, and to also advocate for people with these disease processes. So there's several components to registry. So a clinical data registry does gather information about a patient's health status and the care that they receive over time. There are different ways in which this data can be obtained. Sometimes it's obtained through filling out some forms. from a hospital, for example, or other times the data can be taken directly from medical records, but the data is all de-identified. So in a registry, you can see longitudinal data for someone, but you don't know who that someone is. Different registries can track different aspects of care. So today, of course, we'll be talking about type 1 diabetes registries. And the data that's obtained from registries can be used for treatment analyses. And they can also help improve healthcare quality and safety. So I really like this image because it shows what countries have national diabetes registries. And these are really great sources because it allows various institutions or practices within a country to see how they're doing and learn from their peers. And so the countries in green are the countries that have diabetes registries that are nationalized, and the countries in red are those that don't. And as you can see here, the United States is one of the countries that does not have a national diabetes registry. Registries can also help feed data into a learning health system. So what that means is that registries first allow you to see how you're doing and benchmark your outcomes or your processes against peer institutions, and they can lead to changes in health and care delivery, quality, and safety. And a learning health system is a system in which the data and the experiences are integrated with external evidence and put into practice. And this usually involves QI methodology. And so the figure on the right shows that practices generate data, and data plus research findings can be integrated together for evidence that can help improve practice. And the main goal is really to improve patient outcomes. And so here's an example of several pieces of registry data looking at hemoglobin A1c across the ages in 3 different registries. So the first one on top left is the Germany-Austria registry, and it's looking at hemoglobin A1c outcomes in 2011 and 2017. So red is 2011 and blue is 2017. And as you can see in the German-Austria registry, the hemoglobin A1c outcomes have improved. If you look at the data out of Sweden, which is, sorry, I reversed my colors. Blue is 2011, red is 2017. And on the right, which is the data out of Sweden, there's been a great improvement in A1c outcomes between 2011 and 17. And then on the bottom left is, I think, the data that everyone has seen in the US, where our outcomes have gotten a little bit worse since 2011. And so what this really shows us or helps us think about is, what has Sweden done that's helped improve their outcomes, and what can we learn from them? And the other place where registries have really been important is during the COVID-19 pandemic. And I'm not going to go through all the data here, but this is data out of the T1D Exchange QI initiative, the Sweet Diabetes Registry, as well as the DPV registry from Austria and Germany, talking about the effects of COVID on people with type 1 diabetes. And so this really has helped to increase our understanding as providers of COVID in people with diabetes. And so I really want to talk about successes that clinics have seen from QI-based approaches to type 1 diabetes. So the first registry I want to talk about is the NPDA, or the National Pediatric Diabetes Audit. This registry covers most of the clinics in England and Wales. It was established in 2003, and the goal was to support professionals, families, and commissioners to improve care in pediatric diabetes units. And they measure their effectiveness against their national guidelines, which they call NICE. And the guidelines in the UK are A1c goals less than 6.5%. And they want to make sure that people also get appropriate screening for diabetes complications. And so this is something that's really, really optimistic. So in their registry and their learning health system, when they started collecting data back in 2009, the median A1c was 8.8%. And over a 10-year period, they've been able to drop that A1C down to 7.7%. So not at what their goal was, but they have shown great improvements in care. And one of the ways in which they've done that is with what they call open benchmarking. And so all of this data is available on the internet. Anyone can look at it. But on the bottom, they have all of the pediatric diabetes centers. And on the top, the y-axis or the left, they have the percentage of children and young people who met A1C targets. And they've plotted this out. So for example, if you're the clinic on the far right, you have about a quarter of your population who are reaching their A1C targets, whereas the group on the left is under 5%. And so there's definitely some differences in either the population or the care between those two centers. But at their meeting, the two centers can get together and share their practices and adopt best practices. And so by doing this, when looking at this nationally in the registry, the percent of people meeting the A1C target has improved over time to about 22% nationwide. And the other thing that has also changed over the same time period is the rates of screening for diabetes complications. So aside from A1C, which was at relatively high numbers early on, but blood pressure, BMI, urinary studies, cholesterol, eye exam, foot exam, and thyroid studies. And so because this data is being tracked and centers are being provided data, they've focused their efforts on improving the consistency of the care delivery. And as you can see, the rates of all these screenings have gone up. Another success story is from the Swedish Pediatric Diabetes Registry called SweDiabKids. And this registry was established in 2000 from all of the pediatric centers in Sweden. So it's about 42 centers. They also engage in open benchmarking. And in this plot, the blue is all patients, the yellow is gold is boys, and the red is girls. And what you can see is between 2013 and 2020, there's been a decrease in hemoglobin A1c from about 7.5 down to close to 7. So again, they have similar processes to what they do in the UK, where centers are benchmarked and best practices are shared. So I want to talk about some lessons from registry data. And so this is where I'm going to focus on what they've seen. So in the Swedish Diabetes Registry, they have two different registries, one for adults called the Swedish Diabetes Registry and one for children called SweDiabKids. And they collected data from 1998 to 2017. So they had a total of 10,398 people who had diabetes for at least 8 years. And they included all people who had data from early in onset, and they looked at complications. And what they found was that the risk of developing retinopathy or microalbuminuria or macroalbuminuria, so that's a complication where you have protein in your urine, was similar between people who had an A1C under 6.5 and those whose A1Cs were between 6.5 and 6.9. And I think this was really important data because going to those lower A1Cs does add to the burden of diabetes care. And so really it was showing that people don't need to push for lower A1Cs in order to decrease their risks of complications. And so another registry that we're part of here at Stanford is called the SweDiabKids Registry. So it was established in 2008, primarily of centers that were in Europe, but now it's, as you can see in the map, it's expanded worldwide to over 100 centers. As part of this registry, participating centers share data twice a year, and they get benchmarking reports, which shows their outcomes relative to the other centers in the registry. As part of this process, they also do reviews of centers to establish what they call centers of reference. So those are centers that provide high quality care. Again, this started primarily in Europe, but they're now expanding their hubs throughout the world. And so there is now a North American hub that does the United States, Canada, Mexico, and may do parts of South America. Some of this expansion was slowed by COVID-19. And so as part of this, Stanford was the first center of reference in the United States, and we've worked to do these peer reviews of a center in Calgary and a center in Toronto to help them get certified as well. We had hoped to do a lot more, but as you can imagine, COVID over the last 2 years has made this challenging. But going to review these centers is really enlightening because as a provider, I get to learn a lot about how diabetes is taken care of in other parts of the world and adapt some of those learnings for ourselves. So the Sweet Diabetes Registry did benchmarking over their first 10-ish years. And so on the left-hand panel, they are looking at A1c outcomes in the entire Sweet Diabetes Registry. The blue line is the 2008 to 2010 cohort. So that's the group early on, primarily centers from Europe. And then on the green is the 2016 to 18 cohort, which includes an expanded set of centers. And what they have found is that there have been improvements in A1c between 2008 and 2018 across all the age groups. And then they've also looked at the role of technology, or how much technology is available in the Sweet Diabetes Registry. So the black bar is patients who are meeting A1c targets. The dark gray is patients on insulin pumps, and the lighter gray is patients on continuous glucose monitors, or CGM. And so between 2008 and 18, there has been a slight increase in patients meeting targets. There's been a slight increase in use of insulin pumps, and there's been a large increase in the use of CGM. And another piece of data that's really been shared, and I think is important, is in terms of outcomes, is that consistent A1c target setting is associated with improved outcomes. So this was originally demonstrated in the Hemoglobin study, which was a collaboration of 26 diabetes centers in 23 countries in Europe, Japan, North America, and Australia. And this was published back in 2013. And what they really found was that consistent A1c target setting by a diabetes care team is associated with improved A1c outcomes in a given clinic. And so the Sweet Diabetes Registry conducted a similar study starting in 2019 and going into 2020, where centers were surveyed to what their A1c targets are. And they found that centers that had lower A1c targets had a larger percentage of people meeting glucose targets, as well as lower A1c. And this is another piece of data from the Sweet Diabetes Registry. My slides are free, can be freely shared. So I'm not going to go through every single line, but this was looking at the use of CGM and insulin pumps in the Sweet Diabetes Registry. And what they found was that use of diabetes technology was associated with lower A1Cs, and as well as lower rates of decay and severe hypoglycemia. So what these registries are not showing are the roles these play in quality of life, but what the registries do show is that these can really be beneficial in glycemic outcomes. And this is another study out of the Sweet Diabetes Registry looking at A1c outcomes in the first 18 months of diabetes diagnosis worldwide. So there is some data to suggest that your A1c trajectory early in the course of diabetes can set your trajectory throughout your life. And so so there's been a lot of focus on improving outcomes early in diagnosis of diabetes. So on panel A, the entire Sweet cohort, A1C is highest at diagnosis, usually decreases by about 4 months of diagnosis, and then slowly increases for the remainder of the 18 months. Panel B shows there's no significant difference between girls and boys. Panel C shows that Initially, people who are a little older when they're diagnosed, so over 9, tend to have a little bit higher A1c, but that A1c is usually lower by month 4 to 5 of diagnosis. But the A1cs are pretty steady at the end of 18 months. Panel D looks at use of pump and versus injection, and at least in the Swedish Diabetes Registry, there was no significant difference in outcomes. But this kind of looked at any pump or CGM use in the first 18 months, and so it didn't look at specific trajectories after initiation. I find panels E, F, and G very interesting because this looks at regional differences. So panel E, the Swedish cohort was divided into 4 different groups. Europe was very large, so it was divided into Northern Europe and Southern Europe. South America, Asia, Middle East, and Africa were grouped together because even though they're from around the world, they have similar economic characteristics, and then North America, Australia, and New Zealand were grouped together for that reason. And so the North America, Australia, and New Zealand cohort, which is the red, actually had the highest A1c throughout the trajectory, while those from Europe had the lowest. And the under-resourced countries, South America, Asia, Middle East, and Africa, tended to be in between. Panel F shows the difference between nationalized insurance in blue and non-nationalized insurance. And as you can see, there's definitely a big difference in trajectories. And then panel G is looking at gross domestic product among countries in the Swedish Diabetes Registry. And what this is showing is that having a higher GDP does not necessarily translate into lower A1Cs. Again, this data is from the Swedish Registry, so it's from across the world. Not every center in every country is represented in the Swedish Registry, so there may be a little bit of bias in whose data we have, but the data is really just interesting to see outcomes across the world, and it's an opportunity to learn from other people. And then this is looking at hemoglobin A1c outcomes in the Type 1 Diabetes Exchange Research Registry. So this is not exactly the same as the QI registry. So this was a research registry which many of you may have participated in, where data is collected from people who consent to be in the registry. And so this is looking at hemoglobin A1c outcomes across ages and based on technology use. So panel A up top is showing that people on pump tend to have slightly lower A1c than people on injections. Panel B is showing the differences based on CGM and users and non-users. So CGM users tended to have a lower A1c. And panel C is looking at the combination of technology. So what this is showing is that people on pump plus CGM, or even injections and CGM, tend to do better in terms of A1c compared to those who are on injections only or pump only. And so now I want to move on to a different Type 1 Diabetes Exchange Registry. So before was the Research Registry, and now it's a Quality Improvement Registry. So this was a newer registry established by the T1D Exchange back in 2015. This fits the definition of a learning health collaborative, where data is shared across sites, and the goal is to really encourage sharing and adoption of best practices. Originally, when this started and I started working with the T1D Exchange, there were only 10 sites, 8 pediatric and 2 adult. Now there are over 40 sites, both pediatrics and adult. I believe there's about 30 pediatric sites and 10 adult sites, but the goal is to grow the number of adult sites. What I think is really exciting about this registry and this learning health system is that it takes the voice of people with diabetes and parents of children with diabetes really into account. So there is a steering board comprised of people with diabetes and parents of children with diabetes, and they're really an integral part to helping run the registry, as well as providing feedback on some of the interventions, even language around diabetes, helping make more person-centered care. So this is something that's very unique to this Quality Improvement Registry. And then lastly, as I mentioned, the goal is to really share learnings. And so our motto is to shamelessly steal. So if a site were to talk about something that really helped improve care in their clinic, is actually encouraged to share and use those learnings in our own practice. And so the T1D Exchange QI is based on the chronic care model that really takes into account community resources, policies, the health system, self-management, system design, decision support, clinical information systems, and really the goal is to improve outcomes. The primary aim is to improve glycemic control, reduce severe hypoglycemia, and advance the quality of life and decrease the burden of type 1 diabetes. So this has been the goal for the last about 6 to 7 years. And as we're entering phase 2, we may revise these goals some more. And looking at this, there are some key drivers of improving outcomes and some examples of interventions, which feel free to look at. And so the T1D Exchange is really in its infancy with respect to data collection. So the T1D Exchange QI uses electronic health record method where data is shared directly with the T1D Exchange. All of the data is anonymized, but they have access to things such as demographic factors, for example, which is not available in Suite. So there's a robust amount of information. So what the T1D Exchange QI had been focusing on early on was basically benchmarking and doing small tests of change to improve care. So one of the factors that they were looking at is to increase the use of diabetes technology. And so we had 2 parallel process studies going on. One is looking at increasing CGM, and the other was looking at increasing pump use. I pulled the data from increasing CGM use just because it was a nice figure, but the sites that participated in this started working on this back in May of 2018. And about 34% of users were using CGM, and the 10 participating sites, both pediatric and adult, really focused on efforts to increase CGM uptake. And then by February of 2020, CGM use had increased to 55%. And in the paper on insulin pump use, there was improvement in insulin pump use based on some QI initiatives. And in both of these manuscripts, there's a discussion of some of the interventions that were successful. And then this is also data from the T1D Exchange looking at CGM use and the rates of DKA and severe hypoglycemia. And so again, this is real world data. So this is data that we are observing from people who are receiving routine care. And the rates of both DKA and severe hypoglycemia are decreased in people using CGM compared to people who are not. And just like technology and A1c are important, mental health is really important in the care of diabetes. And there was a study looking at the association between depression symptoms and glycemic outcomes in adolescents with type 1 diabetes. And again, feel free to look at this data more in detail, but the take-home message is that having symptoms of depression is associated with an increased risk of an elevation in A1c and short-term complications. And while all of these are not data that's gonna data in itself that necessarily leads to change, it is helping us as care providers in collaboration with our patient parent steering board to come up with interventions to address these issues. And so this was some data that was presented at the ADA, American Diabetes Association conference last year, looking at hemoglobin A1c outcomes in centers that participate in the T1D Exchange QI. So the yellowish orange is 2017 when we started, and the blue is 2020, which was the most recent year that data was available for. So in centers where there was a focus put on improving outcomes, hemoglobin A1c did decrease in that time period. And the other thing I really want to talk about is these registries really do highlight disparities that occur in diabetes outcomes. And And I think this is really important because we want to make sure that no one is left behind as diabetes care evolves, as technology becomes more prevalent. So the NPDA, which as a reminder is the registry from the UK, on the left panel is looking at A1c outcomes based on race. And so what this is just showing is that Black children tend to have higher A1c compared to the other groups. And then if you look at the panel on the right, on the left side is by ethnicity again. So children who are Black or Asian or other tend to have lower technology use compared to, CGM use compared to those who are white. And on the right-hand side, it's looking at it based on economic quintile. And so they use the word deprivation. So the most deprived or the lowest quintile tends to have the least amount of technology use, and the highest SES group tends to have the most amount of technology group. So this is helping the people in the UK try to bridge their gaps. And similarly, the T1D Exchange QI was looking at A1c disparities in people based on race and ethnicity. And so what they were able to find is that non-Hispanic Black youth have the highest rates of DKA, significant hypoglycemia, serious hypoglycemia, and the lowest use of diabetes technology. And this also persists in the T1D Exchange Research Registry. So these 4 panels are looking at A1c outcomes as well in corroboration with technology use. So in panel A, that's just looking at all comers. And as you can see, those who are non-Hispanic white have the lowest A1c, that's green, whereas those who are non-Hispanic Black have the highest A1c, that is the dark blue. In panel B, it's looking at this based on CGM use. And the average A1c, the gaps in A1c, panel B is looking at no technology use, and as you can see, the gaps remain when you have no technology use. Panel C is looking at it based on pumps, and as you can see, pumps tend to narrow that gap. And panel D is looking at CGM, and CGM also tends to narrow the gap, but the gap is not completely closed. So there are factors beyond technology that can lead to disparities. And so I just want to tell you a quick story about how we've used learnings from registries to change our practice. And so we have a program going on called the 4T program: Teamwork, Targets, Technology, and Tight Control. And so we use learnings from the Itchviador study as well as SWEET, where teamwork is really key. So teamwork is all the care providers in the clinic, but also people with diabetes and their parents. And we have been working on having a consistent target message across all providers. We show, based on registry data showing that outcomes differ even early in diagnosis, we did talk with colleagues in Europe who talked about the more intensive education that youth receive early in diagnosis. So I was at a meeting for SWEET and was talking with a provider from Portugal. So if you're diagnosed with diabetes in Portugal, you're hospitalized for a week. And if your A1c is ever over 9%, or you end up in DKA, you get hospitalized for another week for re-education. We don't want to do that, but we did want to learn and intensify our educational program early in diagnosis. And then there's also registry data showing that CGM is associated with improved outcomes. So we have started initiating CGM in all of our patients at diagnosis. So our average time to CGM starts about 7 days. We provide the first month of supplies, and for people who, and then we apply for insurance coverage. And for people where the insurance coverage is delayed, we will provide some backup supplies. And for our patients who are on public insurance, where getting approval is a little more challenging, we do have some philanthropic funding to provide them with CGM. And then the last learning we wanted to use is that there are disparities in technology access, and that's why we made a decision in our clinic to provide CGM to all patients regardless of socioeconomic factors. And so here's some data from our study. So in this program, all youth with new onset diabetes are started on CGM in the first month of diagnosis. We've increased the number of visits in that first month just to have more touch points and more education. So we do our new onset teach. We do a CGM start appointment. We do a 1-week CGM follow-up appointment. Then we do our regular 1-month visit, and then we space it out to routine care. And so what we see in panel A is looking at people who were diagnosed in our historic group. So that was 2014 to 2016, and the blue is our 4T group. And what we've shown is a 0.5% decrease in A1c in the people who've gone through the 4T program. Another component of the 4T program is remote patient monitoring, where the CGM data is being shared with us, and weekly one of our diabetes educators will review it and provide dose changes. This was a later addition to the program, so the first 46 patients did not receive remote patient monitoring, and so they're in the dashed line, and the solid blue line is those who did receive remote monitoring. And so we're able to see and so 0.5% increase with the program, and with remote monitoring, we're seeing about another 0.1 to 0.2% improvement in A1c. And so just want to talk a little bit more about practical learnings for parents and people with diabetes based on the learnings from registries. So I think everyone knows this, but diabetes care is really a partnership between people with diabetes, parents, and the medical team. It's really important to have consistent glucose target setting to help improve glycemia or glucose levels. An A1c of 6.5 to 6.9% is effective in decreasing the long-term risks of diabetes complications. And CGM is a really effective tool and is associated with lower A1c, DKA, and severe hypoglycemia. There are disparities that exist in diabetes outcomes and technology, and it's really important that as a society we address this. And then I think one of the biggest learnings is it's really important for people with diabetes and parents to get involved in local QI teams to help influence changes that improve care. When the T1D Exchange QI started, not all of the teams had patient-parent representatives, but all of them are now bringing patient-parent representatives along. And last piece is it's really important to advocate for the community, but it's also really important to advocate for yourself. And I just want to talk a little bit more about what's coming up in the future with registry work. So registries in general are now evolving to learning health systems to share best practices. It's been recognized that people with diabetes and parents are really crucial to this. And so there are efforts now to involve people with diabetes and parents in learning health systems and registries to make it more person-centered. There is more increased attention on mental health in people with diabetes and their caregivers. And I think this is something that the T1D Exchange QI really is focused on. And there are efforts to improve depression screening, sharing methods for depression screening, and how to operationalize it. The T1D XQI has a key focus as well as decreasing disparities in outcomes and technology use. I think I mentioned this before, that registries give a lot of information that helps practices better deliver care, but the care can still be personalized. But I think the other piece is that improved data collection in general can lead to more personalized care by learning from people who are similar. And then registry data really can be key for advocacy efforts. So I want to just say thank you, and I'm happy to take any questions.
Great. Thank you so much, Priya. That was really informative. I know it's a lot of information, and I think, having these last points about how important the registries are for us as people living with diabetes or loved ones of people with diabetes is really helpful. And I think, one of the other things is talking about sort of why you got involved in working with the registries? Like, what was your motivation?
Yeah, I think thanks, Marissa, for asking that. So I've always really been interested in trying to improve outcomes for all of my patients with diabetes, but also in increasing technology use and decreasing disparities. And as part of this, what I realize is that we need data to learn from. And so when I first started, I got involved with the T1D XQI, and we were really working on what data do we need as a community to best serve our patients. And so what this has been really eye-opening for me is it helps us realize where we do well, where we have gaps. And I think that in the medical community, people are now much more open to open benchmarking. So I can see what my A1C, my clinic, I should say, A1C outcomes are, for example, compared to another clinic's. And we can share our best practices. And I think all of this really serves to try to improve patient outcomes, experience, and care.
Absolutely. And I think, from the perspective of someone living with diabetes or their loved ones, why do you think it's most helpful for us to participate or contribute data or, participate in research on these registries?
Yeah, so I think, I think one of the concerns is a lot of the data, we're getting longitudinal data on people with diabetes. And I think I really want to emphasize that data is de-identified. So even me as the provider, if I see the data, I don't know who the patient is. But I think it's really important that we gather this data because it helps us see our gaps and our successes and learn from other people. And I think it's something that really can help the community. So there have been research studies showing improvements in CGM. There have been research studies showing improvements in pump or closed loop systems, but research study environments are very different than your lived experience. You're getting a lot more contact with your research team. There's a little bit of bias in who participates in research, just because of the demands, in terms of visits and follow-up that's required. But this really shows the lived experience, and so it can give feedback to us as healthcare providers on how we can improve the experience or the delivery of care or talking about these technologies. But I think it also can provide information to manufacturers that, hey, this particular system just didn't work in people, and why is that? Learn from it. And then I think the other question was, why should people with diabetes participate in research? So I think the big reason to participate in research is, I think, we all want to improve the life of people with diabetes, and the goal of research is to do that. And so to improve the quality of life, decrease the burden, and improve outcomes. And so we do need people who are going to volunteer their time and their energy to test out whether it's a new medication, a new piece of technology, or a new system, because those learnings from research is what leads to changes in care. And then once that's widely deployed, that's what can lead to some of the data feeding back into registries and helping deliver more personalized care.
Absolutely. And I think, the other piece, and I'm not sure if this was mentioned, was when you have this data and it's collected on people from all over the world, all over the US, and it's showing, like, without a doubt, CGMs make a difference and insulin pumps make a difference. It really puts pressure on the insurers, in the case of our country where we have the private insurance and we have, CMS, that's Medicaid and Medicare. It really shows them, like, hey, these devices might cost you a little bit up front, but it actually saves you money in the long run. And I don't know, from my understanding, I'm assuming that the 4T study that you guys were working on at Stanford, where you started the CGM early, helped get Medicaid coverage in California. Do you think that it did help contribute, or?
So I think the 4T study came out a little later than the approval, but I think there has been a lot of studies looking at the use of CGM in the Medicaid population, including from our center. So there's really old data from, I want to say 2010, that shows that youth who have higher A1Cs or from minority groups or marginalized communities don't do as well on CGM. So it may be a waste of money, or they don't continue to use that device. And but those were really not the best CGMs. The newer CGMs, for example, don't require calibration. They're more accurate. They're components of automated insulin delivery systems. So there's been a lot of focus on giving people these CGMs, whether in research or in quality improvement, and looking at the outcomes. So for us, for example, we had originally done a study looking at just the differences in A1C outcomes or use of CGM in people in California in our clinic who were on Medicaid, and we were showing high levels of use. And then we did a follow-up study looking at CGM coverage. And what we saw was that people who had CGM, but not just CGM, continuous access to CGM, had lower A1C. But anytime you had gaps in care or you lost CGM, your A1C went up and it never came back down. And so those two pieces of data combined with data from other states really did get California to change their policy for the pediatric population, where CGM is now covered for all patients with type 1. And we've even been fortunate enough to get CGM now covered for patients with type 2 on insulin.
Oh, that's awesome. Yeah, I mean, it seems very logical to me that if you, as a person living with diabetes, which I am, have access to your data and have this direct feedback of, when I eat 12 Oreos or whatever it is, like I'm high for hours, and that's not a great feeling. Like it's just, and everyone's going to do their own thing, of course, everything in moderation, right? But it's just, there's something really valuable in having direct feedback from a device that isn't, it's not your partner like, oh my gosh, why is your blood sugar high? Or your parent like, oh my gosh, why is your blood sugar high? Like we know what we need to do most of the time. I think it's just hard to do the same thing every day or eat the same thing, or there's Easter candy, sometimes I want to eat the Easter candy.
Yeah.
And things like that. So I think it's really helpful to collect this data.
Yeah, and I think, the other piece is now with automated insulin delivery systems that are able to do low glucose suspend, auto corrections. I mean, that's really going to change diabetes care and burden, hopefully. And so CGM is a huge component. Without CGM, those systems can't work. And so I think it's really important to cover CGM to help facilitate automated insulin delivery systems. Prior to this change in California, for example, pumps were relatively easy to get compared to CGM. I mean, you still have to check your blood sugar 4 times a day for a month and send in logs, but that was easier than what the CGM policy had been. But now with automated insulin delivery, we're like, you don't want to give someone a pump without a CGM unless they really want it. And so that also helped to change policy. And just as an aside, for the next phase of our 4T study, we're encouraging automated insulin delivery use in the first 3 months of diagnosis to see if that can improve not only outcomes but quality of life, because we are doing quality of life measures as well.
Yeah. And I think it's interesting because I feel like when the hybrid closed loop systems first came out, I personally heard a lot of providers that were so afraid that, people would start on these systems and forget what to do if the system fails. And, I know, for example, one of your colleagues, Rayhan, when he was on call, had a patient, a parent actually call in the middle of the night and was freaking out because the Dexcom wasn't working. I don't know if it was a restart or, there's that gap of 2 hours. And, he said, well, you can poke your child's finger. And she was like, what? Just the thought of doing something, which was the only thing that we had, for a very long time. But I think, it's so wonderful to just try it, because you're still going to teach them the backup methods anyway.
Right.
And I think there's less fear in like the de-skilling that people have been worried about. And collecting this data and showing like, hey, guess what? When the tools are taught well and when they're started and they have this access, they actually do pretty well.
Mm-hmm. Yeah, I completely agree. I mean, I think we were worried about the de-skilling as well, but I mean, in our time, we've had people who've lapsed in insurance coverage for their CGM, or there's been a shipment delay, and people, there's this moment of panic, of course, but then they're like, oh, wait, I have that glucometer in a box in the back of the closet. Let me go pull it out.
I know there is something so freeing about not having to check your blood sugar all the time, like just having the access on a smart device. And I saw recently that in the UK, they're also now providing CGM, or they approved it for all people with diabetes. Is that right?
I think so. I read that as well.
Yeah. So I think, the other question I had, because from my understanding, a lot of the other developed countries, if you will, are meeting goals a bit better than we are in the US. And I don't know if there's been a whole lot of research on figuring out why.
Yeah, I think people are trying to figure out why. So, for example, just starting at base level access, right? Most of those European countries have nationalized health insurance. They're plugged into endocrinologists or providers who can care for their diabetes. Over here, it's a lot more challenging. And people don't live as far from their providers there. So like we have some patients who come to us from like 4 or 5 hours away. Telehealth has helped change some of that, but still it's quite a distance. They get paid time off to come to clinic. Over here, you have to either use PTO or go without pay. So I think there's that base level of just access. In many of those countries, people don't worry about insulin. That's a concern here. Many of the European countries, for example, Germany, was giving Libres to people when they were a diagnosis. Like everyone was hospitalized for nuanced education, but they walked out of the hospital with the Libre.
Wow.
And so Libre in Germany is the equivalent to doing a glucometer here. So I think there was the technology access. And then I think the other piece that there's not enough information about is some of the social determinants of health, for example. So SWEET doesn't capture that. Some of the European countries capture it, other countries don't. And so we're starting to be better about capturing it here, but there's a lot that comes into play, with respect to systemic racism, food insecurity. And so I think that's the other piece that we really need to look into: language barriers. So if you're seeing a provider and you don't speak the language, you may have an interpreter, but there may be things that are lost in translation. There are sometimes cultural barriers. So we've had a couple of physicians who've worked with us who've come to us from India, for example. And over there, people who have diabetes don't want to let other people know who have diabetes because it's a huge social stigma. So, for example, they may not take insulin while they're in school because they don't want people to know they have diabetes, or they may just take a lot of insulin, and so they have pretty high rates of hypoglycemia. So I think that's the layer that's going to be the next level that's going to be unpackaged. And of course, there's the psychosocial comorbidities. So I really applaud the T1D XQI for focusing on that and really trying to unpack that as well.
Yeah, I think it's a lot. And, as people with diabetes and their loved ones know, diabetes is also not something that's, just plug and go. It's very, it's ever changing and ever challenging. So yeah, hopefully we can now that, I'm really glad that we have these networks so that when we collect this data, we can, collaborate together. It's a really nice collaboration. So there's a question from the chat. And the question is, with faster CGM access, do you find that people are choosing pumps more quickly as well?
That's a really interesting question. So I was recently looking at our pump use in our 4T group, and it was lower than I thought. And I think I mean, we did have a reasonable number of people on pumps, but I think what's happening is with people on CGM and they're getting more education, more support early on. I mean, they're getting a diabetes educator who reviews the numbers every week and sends them messages to help them with adjustments. So their glucoses are, I think, more in target range for longer periods of time. And so people are sometimes comfortable, or they kind of wait on starting the pump until they see more glycemic variability. And then for a lot of our adolescent patients, they love the CGM, but it's another device to wear. And I think that's another barrier that people, again, that comes down to trying to fit in and being like your peers. So that's another barrier that people are working through. So with our next phase of the study, where we'll be having a pump class introducing people to closed loop systems in that first 1 to 3 months of diagnosis, I think having them exposed to it right at the beginning, I'd really be interested in seeing how uptake of pumps and closed loop systems are in this group compared to the group that just had CGM introduced early.
Yeah, that's a really good point. I hadn't thought about that. Mm-hmm. And then her other question was, since you guys have changed the standard in your practice, like how quickly do you find other clinics making these changes?
Yeah, great question. So, we share our data quite frequently in the T1D Exchange QI, and there are a lot of other groups who are interested in doing this early CGM implementation. We've been lucky in that we have both philanthropic funding and grant funding to help get the CGM into people's hands quickly. Other clinics who may not have that extra financial support rely primarily on insurances. So the manufacturer usually gives us supply, so that's about 2 weeks supply. And then a lot of it will depend on how quickly insurance kicks in. And so there's a lot of effort trying to change the standard of care to say CGM should be given to people like a glucometer is. Like you walk out the hospital like they do in Germany, and here's your CGM.
Yeah, and
there's a lot of interest.
Yeah, and I think too, I mean, with hopefully, Dexcom's new sensor will be out in the next, I don't know when, but once that's out, then you don't have the added expense of the transmitter. In just like the Libre, right. But the challenge with Libre is if you're on the closed loop system, it's not integrated with the Libre, because that's something that we tend to suggest. If people are having trouble keeping up with payments for Dexcom supplies or things like that, we suggest that, but it's not an exactly equal transition.
Agreed. And very similarly, most of our patients are on Dexcom because we can help support them if the costs are high. But I've had one patient who's kind of beyond that first year of diagnosis, so have exited the active phase of our study, where the family has chosen to go on Libre because of the costs. And they are thinking about closed loop system, and if they choose to go on a closed loop, they'll switch back to the Dexcom, but still the costs are really, like you said, really hard.
Yeah,
and there should be better coverage.
Yeah, and I think that's like you said, like we talked about, the difference between this country and like the other countries that are in the SWEET database is, having that nationalized healthcare system. But I do think, the other thing is we are very large. People always call us a melting pot, and it's true. We have a lot of different cultural backgrounds, a lot of different things that, contribute, and we're really big compared to the European countries. And, so even being able to get to an endocrinologist, and, I applaud everyone that goes into endocrinology, because there is much less money to be made as an endocrinologist compared to other physician opportunities. So thank you for choosing us. Oh, gosh. Well, and then we just had another comment just saying that, pumps seem to be really helpful for us. And I would agree. Definitely. Well, thank you so much, Priya. This was really, really informative. And I really appreciate your time. And thanks to everyone who logged in and who checked out our live Facebook feed. I accidentally started it on my page first, but I got it on the CWD page. So thanks for bearing with me on that. And we will have another Screenside chat next month. And if everyone wants to check out our next upcoming events, you can go to cwd.is/community and have a great night.
Thank you, everyone. Thank you, Marissa.
Thanks, Priya.
Bye.
Bye.